And now, without further ado, I'm pleased to present Dr. Scott Cousins.
Thank you, Eva, and let me welcome all our listeners to this presentation. And what I would like to present today is the role of dynamic ICG in the therapy of neovascular AMD that is resistant to anti-VEGF monotherapy. And the take-home message is listed in this slide, that choroidal new vessels resistant to anti-VEGF therapy are not uncommon, that dynamic ICG allows us to visualize vascular morphology of the CNV, and I will introduce this concept of the arterialized CNV, and that these arterialized CNV are generally anti-VEGF therapy resistant, and then finally suggest that there's a role of ICG-directed photodynamic therapy to occlude these arterioles and successfully treat these resistant CNV. So with anti-VEGF monotherapy, we're very used to the kind of response shown in this image. Here's a patient with 2100 pre-treatment appearance and a classic CNV and thick OCT. And then after several doses of anti-VEGF therapy, there's inactive CNV and a thin, compact OCT. But what we're really doing in this kind of case is leakage control, not vascular regression. The blood vessel is sitting there inactive, but is waiting to reactivate and leak again. However, we've all seen cases like this with anti-VEGF monotherapy. This is a patient that received a single dose of Lucentis, and within a month after treatment, the patient showed CNV regression. All evidence of the blood vessel has disappeared. And here's yet of another case of a patient with recurrent CNV off a thermal laser scar. After 7 doses of anti-VEGF, the blood vessel appeared to disappear. We can get some information about how common this type of regression response occurs by looking at the data from Phil Rosenfeld's Pronto study, which was published about a year ago in the American Journal of Ophthalmology. And what he showed in his study was that if you induced patients with 3 doses of anti-VEGF and then monitored them monthly with OCT and examination, what percentage of patients actually re-leaked or never re-leaked? And what Phil showed in his study was that 20% of eyes never re-leaked, 20% of eyes re-leaked but only after 6 months, but 45% of eyes re-leaked within a month or so after discontinuing the initial anti-VEGF induction. What his data show is that there is a variable response to anti-VEGF monotherapy. Some eyes appear to regress, but other eyes were just having this stable control of leakage. I'd like to introduce this concept of VEGF therapy-resistant neovascularization. Just like there were eyes that did extremely well with anti-VEGF therapy, there are cases that do not. So here is an example of a patient whose CNV actually enlarged during the induction therapy. Here's a patient with an occult CNV and relatively low-grade leakage who received 4 doses of anti-VEGF therapy and the subretinal fluid did not resolve. Upon discontinuation of therapy, they developed a submacular hemorrhage. Here's an example of a patient with a serous PED and an occult choroidal new vessel at about 7 o'clock off the margin. We watched the patient for about 8 months. The CNV and serous pigment epithelial detachment enlarged. The patient was started on Lucentis induction therapy, and after the 3rd dose of therapy, they developed a hemorrhagic PED. Clearly, this eye did not respond to anti-VEGF therapy. At Duke, we looked at a series of 99 eyes that underwent induction with anti-VEGF monotherapy and tried to determine the subset of eyes that showed complete anatomic improvement, that is, a drying up of the OCT and stability of the fluorescein, versus those that did not show improvement, what we called resistance. And resistance was defined as either lack of anatomic resolution of the OCT or fluorescein, or frank progression while on therapy. And what we observed was that 25% of eyes could be classified as resistant to anti-VEGF monotherapy. Half of those eyes were eyes with serous pigment epithelial detachments, and I'll address that subset in a few minutes. But 6% of eyes developed actual progression while on therapy, either developing hemorrhages or enlargement of the CNV while on monthly anti-VEGF therapy. The question is why, and how do we get some insight into the pathobiology and potential therapy of these cases? And that's where the role of dynamic or high-speed indocyanogreen angiography comes in. And we've been using the HRA2 for many years, and then recently in the last year we've had the pleasure of using the Spectralis instrument. Unlike standard bright flash ICG, the dynamic ICG shows a video. And in this video of an eye with classic CNV is shown here, what the movie shows is that the lesion is actually composed of different components. There is a feeding artery, branching arterioles, a surrounding rim of capillary, and a draining vein. And one can see the flow characteristics very well when you view the movie. And again, feeding artery, branching arterioles, draining vein, and the capillaries. These components can be shown, again, on a stills taken from the previous video. Again, feeding artery, branching arterioles, capillary, and draining vein. So what dynamic ICG shows us is rather than the classic teaching that choroidal new vessels are capillaries emanating from the choriocapillaris, what dynamic ICG shows us is that choroidal new vessels are actually three different components: an afferent feeding artery, capillary network, and a draining vein. And the point I'm trying to leave is that the caliber and size of the feeding artery determines whether the blood vessel is flow-driven or growth factor-driven. And I'll show examples to that effect in a few minutes. Many CNVs show feeder vessels are these afferent arterioles. Here's an example of an eye in which the feeding vessel develops nasal to the optic disc. Here's an example of recurrent choroidal new vessel after thermal laser. And notice that the feeder vessel that feeds the capillary complex actually begins nasal to the original laser scar, as shown here. Here's the case of a cult CNV and associated with a large feeder vessel and branching arteriolarized complex. And here's a case of a classic CNV with a trilobular branching arteriolarized complex. I don't want to leave you the notion that every case of CNV contains these arterialized feeder vessels. There's actually a range of cases. And I like to use this metaphor of trees to illustrate my point. So small trees have small trunks, and large trees have large trunks and large branches. The tree of life has a huge trunk. An oak tree has a trunk with lots of leaves, and some trees have trunks and branching arteries. And why am I talking this nonsense? Because the trunk represents the feeder vessel, the branches represent the branching arterioles, and the leaves represent the capillaries. And different CNV, different choroidal new vessels, have different representations of that morphology. So we are developing a classification system that tries to subtype CNV by dynamic ICG. So on one side of the classification is the capillary pattern. And these are CNV that have small or invisible feeder vessels, minimal branching arteries, and a kind of a homogeneous capillary pattern, shown in the example on the left. And on the opposite side are what we call fibrovascular PEDs, in which there are long, large caliber feeder vessels, many branching arteries, and minimal capillaries. The arterioles almost form arterial venous shunts. And of course, most cases are mixed pattern in between. What we think this represents is the process of vascular remodeling, in which the capillary acquires a parasite sheath over time, which stabilizes the vessel. And that parasite sheath creates the branching arterioles. At some point, however, the whole vessel gets encased in collagen, and that's when you have these large caliber feeder vessels. Our concept is then those cases that are capillary in nature are the ones that regress with anti-VEGF monotherapy. And those eyes that have these large caliber long feeder vessels are the ones that actually progress or fail to respond with leakage control. And we can only identify which subset the patient has by dynamic ICG. So that hypothesis is illustrated here, that capillary-dominated CNV are the anti-VEGF sensitive lesions, and the arterialized CNV are the resistant ones. So here's a case I showed that demonstrated lesion regression after a single dose of Lucentis, and this patient had a capillary-type lesion that completely disappeared after one dose. Here's a patient with a mixed type of CNV with both capillary and branching arterial components. After a single dose of Lucentis, the capillary portion decreased, but residual branching arterioles were still present within the lesion, even though the subretinal fluid resolved. Here's an example of a patient with minimally classic CNV. The classic component by ICG showed a capillary type lesion, but associated with the occult portion of the lesion was this large branching feeder vessel, which would be more evident if I showed you the video of the case. After the patient received anti-VEGF, the subretinal fluid failed to go away, and in fact the lesion became thicker. And what one observed with the dynamic ICG is that there was some regression of the capillary portion, but the arterialized portion remained unchanged, and that was apparently accounting for the persistent subretinal fluid. So we believe that the arterialization of the CNV account for many of the cases of anti-VEGF resistance. Again, here's a patient with a lesion dominated by large branching arteries, failed to respond to induction with Avastin. Here's a patient with a serous PED associated with branching arteries and the nasal periphery of the lesion, and after receiving several doses of anti-VEGF, the capillary and branching artery portion of the vascular network actually became more prominent, and the PED failed to respond. Here's a patient with an occult CNV that actually did respond with drying of their OCT and consolidation of the CNV after induction. But when the patient was extended and had discontinuation of the anti-VEGF, there was recurrence of the leakage within 1 month. Again, responds after reinduction. And what the ICG demonstrated was that this patient had a large feeder vessel, branching arteries, and a small rim of capillaries that accounted for the VEGF responsive portion of the lesion, and in this case was apparently controlling the leakage. We also believe that these feeder vessels and arterialized complexes explain progression while on therapy. Here is the case of the serous PED that enlarged and developed hemorrhage while on Lucentis therapy. The corresponding high-speed ICGs are shown here. At the time of initial presentation, the patient had a large bifurcated feeder vessel with branching arteries and a very small amount of capillary portion. In spite of receiving anti-VEGF therapy, this feeder vessel complex continued to enlarge during the induction therapy. And clearly, this lesion is not VEGF responsive. Here's an example of a patient with peripapillary CNV who did very well with anti-VEGF therapy, showing that the lesion became inactive, skipped a single injection, and there was a recurrence. Patient was reinduced. The recurrence enlarged in spite of reinduction, and ICG demonstrated that the patient had a large caliber feeder vessel with many branching arteries and minimal capillary portion. Again, these branching vessels and feeder vessels do not appear to be anti-VEGF responsive. Here's a patient with a small classic CNV, received Macogen, the CNV enlarged, received a dose of Avastin, and there was a dramatic enlargement. The ICG demonstrated a trilobulated feeder vessel complex, again with minimal capillaries. And again, a case that I showed previously with an occult CNV, large arterialized complex, and this patient hemorrhaged upon discontinuation of their anti-VEGF. We also find that high-speed ICG is incredibly useful in explaining serous PEDs that fail to respond to anti-VEGF therapy. When I was in training at Bascom Palmer and working with Don Gass, he made the observation that PEDs that had a notch often demonstrated choroidal new vessels within that notch. And that caused Don to postulate that all serous PEDs are manifestations of neovascular AMD. In the modern era, that would suggest that theoretically these lesions should respond to anti-VEGF therapy. Interestingly, in the same era, Alan Bird at Moorfields Eye Hospital, London, proposed that serous PEDs were actually manifestations of non-neovascular AMD. He and John Marshall had postulated that lipid-rich drusen created a barrier to the movement of water, and as we all know, water is pumped out from the RP into the choroid capillaris. What that would cause then is a blister-like elevation simply from the normal pumping action of the PED. And in this example of a fluorescein, there is no evidence of neovascularization within the notch. In this kind of case, caused Allen to propose that serous PEDs were in fact manifestations of dry AMD. However, this very patient presented to me one day after carotid artery surgery, and the surgeon thought that he had flipped an emboli to a branch retinal artery, but in fact what the patient had was a feeder vessel with some polypoidal characteristics within the notch of the fluorescein, not visible by fluorescein. The blood vessel did not grow overnight. What happened was the eye went from a low flow to a high flow state because of the carotid artery surgery, and the new vessel complex became highly perfused, leading to the leakage and the formation of the subretinal fluid and PED. This is a case that demonstrates that blood flow through the CNV contributes to leakage. One can show that serous PEDs also have capillary and branching arterial patterns, as shown in these two examples. And what we've observed is that serous PEDs can also demonstrate polypoidal choroidal vasculopathy, which is typically thought to be rare in Caucasians, but is actually quite common in serous PED, only imaged by dynamic ICG. Here are the two polyps within the lesion, and there's the actual feeder vessel feeding the polyps. We've looked at a series of 35 consecutive serous PEDs imaged by ICG. 30 of the 35 actually had marginal choroidal new vessels that were not well defined by fluorescein. 15, or half of these, had prominent feeder vessels, 5 had capillary pattern, and 10 of the 30, a third of them, had polypoidal choroidal vasculopathy. 5 of the serous PEDs had no CNV, so it turns out that Don Gass was closer to the truth than Alan Bird was in this case, that most serous PEDs actually are a manifestation of neovascular AMD, and that's only detectable with dynamic ICG. So the question then arises, what do you do with these anti-VEGF failures? And we would like to propose the concept of ICG-directed photodynamic therapy rather than the standard approach, which is fluorescein-directed photodynamic therapy. So here's a case of a patient with a serous PED. They received 3 doses of anti-VEGF therapy. The PED failed to resolve. Their vision remained poor. Dynamic ICG demonstrated the patient had a large caliber feeder vessel and many branching arteries, minimal capillary. What we decided to do was to apply photodynamic therapy directed at the trunk of the feeder vessel where it begins to branch into the branching arteries. And this patient showed an excellent response with closure of the new vessel complex, flattening of the PED, improvement of vision. Here's another example of a serous PED associated with a branching vascular complex in the margin, shown here. Interestingly, fluorescein showed 2 sites of leakage, but dynamic ICG demonstrated that the true leaking blood vessel was along the 5 o'clock meridian. We applied photodynamic therapy to the vascular complex identified by ICG. The patient's pigment epithelial detachment disappeared and the vision improved. We also do this ICG-directed PDT treatment for patients with standard choroidal new vessels that fail to respond to anti-VEGF therapy. Here is the patient that I showed previously whose CNV dramatically enlarged while on induction therapy. We directed the ICG to the center of the complex, and post-treatment, the entire complex closed down and the anatomy improved.
Dr. Cousin?
Yes.
I have a question. Can you explain the IVK?
Yes. When I show you the results of this study, it's a mixed bag because it's a retrospective review of our experience as we evolved our treatment. But some of these patients received triple therapy. So triple therapy would be defined as photodynamic therapy, intravitreal Kenalog or intravitreal triamcinolone, with or without a pretreatment with an anti-VEGF. So by IVK, we're really referring to an intravitreal Kenalog therapy, which is often administered immediately after the photodynamic therapy. Here's another example of a case of a patient who received multiple doses of anti-VEGF therapy. The lesion seemed to become inactive, surrounded by a zone of fibrosis. Patient skipped an injection, and there was dramatic enlargement of the lesion. What the ICG showed was that the patient had a large central feeder vessel, many branching arteries, and minimal capillary portion. We applied photodynamic therapy to the center of the lesion and shut down perfusion to the entire lesion. Interestingly, we find that the autofluorescence function on the spectralis is very useful in helping us predict visual recovery. What this case showed with autofluorescence was, in fact, that there was loss of the central autofluorescence, explaining RPE atrophy and the patient's poor central vision. But one might expect bare count fingers vision for a lesion that involved the entire posterior pole. In this case, the residual autofluorescence was relatively intact. Interesting, when you look at the spectral domain OCT at the boundary between involved and uninvolved retina, even though we did not treat it with photodynamic therapy, the outer retina still is abnormal, associated with a choroidal new vessel, whereas at the boundary of uninvolved retina was relatively normal. The whole point of ICG-directed PDT is to minimize the amount of photodynamic therapy directed at the lesion to avoid collateral damage. And here's the last example of a patient. Again, this patient showed partial response to anti-VEGF. We applied photodynamic therapy just to the feeder vessel complex, and the subretinal fluid resolved after treatment. So here is our study. We currently now have about 60 patients, but in our last review, we reviewed 34 eyes from 34 patients. All CNV had arterialized vascular complexes by dynamic ICG. There were two criteria for inclusion in this study: lack of anatomical improvement, and most of these eyes were serous pigment epithelial detachments, or progression while on therapy. And there were 8 eyes that were actually getting worse while they were on induction therapy. All eyes received PDT directed towards the feeder vessel as imaged by the dynamic ICG. We used a 1,000 micron spot size. 17 eyes received full duration PDT. 19 received half duration PDT. We tend to use half duration PDT when we're treating over the fovea, but if we're treating a feeder vessel that is eccentric to the central fovea, we then will use full duration PDT. All eyes received intravitreal triamcinolone or Kenalog immediately after PDT, typically 2 milligrams, and 20 of the eyes received an anti-VEGF therapy within 10 days prior to PDT. We were able to, remember, these are all eyes that one way or another were resistant to anti-VEGF monotherapy, either continued leaking, failed to anatomically resolve, or actually got worse while on therapy. We were able to improve 28 of 34 eyes after the first treatment. 4 additional eyes responded to retreatment. The mean visual acuity gain was approximately 1 line, with 8 eyes, 8 of 34, gaining 3 or more lines. We had 1 eye that actually lost vision due to a hemorrhagic complication. The durability, we're still working out. It appears that the majority of eyes, a single treatment lasts 6 months. But between 6 months and 9 months, as was noted for other forms of combination therapy, we are observing recurrence with additional leakage and reperfusion of the blood vessel. So let me conclude here with the following take-home message. We believe that arterialization of the CNV explains resistance to anti-VEGF therapy, whether resistance is defined as failure to dry up the lesion or the requirement for monthly or very frequent injections. We believe that CNV can be capillary or arterialized with feeder vessels, but this requires dynamic ICG to vision this morphology, and that these arterialized CNV are the resistant form of CNV, primarily due to high blood flow through this large caliber feeder vessel. And then finally, that photodynamic therapy directed at the feeder vessel and the branching arteries, rather than at the capillary as defined by the fluorescein, can be a treatment that's relatively effective in the majority of these cases that otherwise do not respond well to anti-VEGF. So let me conclude here, and I'll be willing to entertain questions. Thank you very much.
Thank you so much, Dr. Cousins, for that outstanding presentation. We actually do have questions, and if anyone would like to send questions our way, we'll be happy to answer those. First is, what is the main cause of reoccurrence?
It seems in about half the cases, there's a development of a whole new vascular complex, especially in the serous pigment epithelial detachment cases. It originates from the same trunk of the feeder vessel, but it's like a whole new set of branching arteries and capillary rim. In a smaller subset, it appears to be reperfusion of the original complex. And at some point, apparently the hemodynamics become severe enough that it starts leaking again.
Excellent. And another question, is PDT plus anti-VEGF therapy not sufficient to stop the disease? And if not, then what should be done?
So that's a good question, and that's been raised many times. Can you just do combo therapy with anti-VEGF plus PDT and skip the potential side effects of the steroid? I can't answer that question from my own experience, but I think it's reasonable. The rationale for the steroid is that the photodynamic therapy is a pro-inflammatory stimulus, and at least in the first few days after treatment, there is a marked infiltration of the choroid with inflammatory cells. Theoretically, you're lessening that with a steroid. If somebody is hesitant to use triamcinolone because of cataract or glaucoma complications, I think one can make a good case for using a shorter-acting steroid like dexamethasone. But it is highly possible that just dual therapy would be good enough. So I can't answer that question.
Thank you. I have another question. Could you visualize the feeder vessels on SDOCT alone?
No, not well enough to treat, but you can sometimes see them as these large caliber structures emanating from the choroid into the subretinal space. So sometimes you can see them on spectral domain OCT, but not enough that you could reliably use that as a substitute for ICG.
Could standard ICG identify these vessels to target therapy?
So we've compared a series of cases with a TopCon static ICG after having already imaged them with a Heidelberg dynamic ICG. So we actually knew where we were expected to find the feeder vessels. And on a series of 6 cases, I could only reliably identify it with static ICG on maybe 1, perhaps 2 cases. And that was only after I knew where to look. The problem with static ICG is you're only acquiring about 1 image every 2 seconds. And it's very easy to miss the key transit phase that you would identify when you're capturing 8 to 12 images per second with a video ICG. So generally, no, you can't. As much as I wanted to try to confirm that static ICG could do this, it does not.
Excellent. Another question. I've used Spectralis for 1 year and lately doing combined therapy for this disease. Which is your usual ICG concentration to better analyze the feeder vessels?
I would have to defer you to my photographer, Michael Kelly, who, if you want to email him, he'll give you our protocol. He's actually he's always looking for ways to improve the contrast and improve the quality of the images. So if you email Eva, she'll forward it to me or to Michael Kelly, and he can get back to you with our entire protocol. He even has a presentation for it. So he'll be willing to do that for you.
I'd be happy to do that. I'll forward that information for you. And we have another question. How many times can you identify feeder vessels?
So my series is a little bit biased because I'm ordering ICGs in cases that are, generally I order ICGs in all serous PEDs that present, but I only order them on CNV when they fail anti-VEGF therapy. So on serous PEDs, we've identified some type of well-defined vascular lesion on 30 of 35 lesions, so that's what, about 90% of lesions. Of those, the vast majority have feeder vessels or polypoidal. If you take run-of-the-mill occult CNV, you can identify feeder vessels on about 45%, some other type of vascular changes in about an additional 40%, 20% you don't see anything. On classic CNV, what we've observed in our recent series is we can see well-defined feeder vessels on about 60 to 70% of eyes, capillary lesions on about 10-20% of eyes, and then not very much detail on about 10%. So in general, we're seeing some type of useful vascular pathology on about 90% of eyes, of which 2/3 of those have some type of feeder vessel or branching vascular complex.
How often do you combine ICG with stereoscopic ICG?
Boy, that's a good question. I was recently in Singapore, and they're developing a technique of stereoscopic ICG, and I was impressed with some of the additional pathology that they're seeing. We haven't started to do that here, but it's an interesting concept. Taking a kind of at the 45-second, once you're done with the actual video portion of the ICG, doing the standard two different views that you did for classic stereoscopic fluorescein, and then trying to identify where some of these late hyperfluorescent lesions are relative to the subretinal space. So we're not doing that yet, but we've entertained the notion of setting up to do that, and it could provide some useful information.
To further elaborate on that question, he asked, do you use directed ICG to RAPs or polyploidal?
So the answer is yes, especially polyploidal. ICG is indispensable for diagnosing polyploidal, and it's a lot more common in Caucasian AMD than we think in America. It's very common, of course, in Asia, but I think it's more common than we've diagnosed previously here. For RAP lesions, we find it useful to diagnose RAP. Most RAP lesions respond well to anti-VEGF therapy, but there are those patients that require once a month or once every 6 weeks treatment. And we do find that ICG-directed PDT to RAP can be a useful adjunct for that subset of patients that either fail to respond to anti-VEGF or need too frequent injections with the RAP lesions. We don't routinely do it, but it comes in handy enough of the time that it's useful.
All right. Another question. How do you treat when you cannot identify feeders?
What I do then is I continue the anti-VEGF monotherapy with or without supplemental steroid, and then I'll re-image the patient a couple months later. Sometimes you don't image something because the photographer did not get focused in the right plane of the choroid. One of the difficulties of this technique is there's a learning curve for the photographer to focus in the right plane where you're looking for the pathology. But sometimes, for whatever reason, you can't always visualize the pathology at the initial test. But sometimes if you repeat it a month or two later, you can actually see the pathology. If I never do fully identify vascular pathology with ICG, I don't use PDT on those patients. I'm uncomfortable just randomly treating the fluorescein without having the ICG morphology as a target.
Thank you. All right. It looks like we don't have any more questions at this time. So with that, I would like to say again, thank you so much, Dr. Cousins. On behalf of all of us at Heidelberg Engineering, I'd like to thank you for that wonderful presentation.
My pleasure. Thank you.
And go ahead, I'm sorry. We actually have another question. I've used stereoscopic ICG, and it's wonderful to see visualization of the complex. So I guess he was just making a comment.
There may be some validity to that. I think we need to start implementing that in our own practice here at Duke. So I'll take that under advisement.
And as you'll notice, I'm displaying our customer support screen. If any of you have any questions, please feel free to contact us anytime. And if you would, please feel free to fill out the evaluation form when you exit your WebEx session. And with that, I'll say for those of you on the East Coast and in the Midwest, have a wonderful afternoon. And to those of you on the West Coast, enjoy the rest of your afternoon. And to all of you, thank you again for joining the Heidelberg Engineering Academy.